Our fifth topic is research featuring Gretchen Brown, who is a Lynch syndrome previvor, and Stephen Lipkin, who is professor of medicine, director of the Weill Cornell program in Mendelian genetics. He is the director of the Adult and Cancer Genetics Clinic and vice chair for basic and translational research in the Department of Medicine. Again, a live question and answer period will be held following the presentations from Gretchen and Dr. Lipkin. Submit questions in the chat feature on Zoom. If you're listening on Facebook, we will do our best to get to the questions submitted in the comments section as well. Make sure we have your email address if you have any needs, anything for us to follow up with. But in the meantime, Gretchen and Dr. Lipkin, all yours.
Hi, my name is Gretchen Brown. I am a 27-year-old living with Lynch syndrome. I have the MSH2 variant. I have known that I have Lynch syndrome since I was about 20 years old. I inherited the Lynch syndrome gene from my mom's side of the family. My mom passed away at 60 from pancreatic cancer. Her mom passed away at an early age from a gynecological cancer. My mom's two little sisters passed away in their early 40s, late 30s. One from colon, one from kidney cancer. So Lynch syndrome has a big effect on my life. In the early 2000s, my mom was contacted kind of out of the blue by one of her cousins. I'm not sure how this cousin found out this information, but she found out that Dr. Lynch was coming to give a talk in my hometown of Louisville, Kentucky, and this cousin encouraged my mom to attend. I guess whatever information was given about this talk, it seemed to be relevant to my family and my family's history with cancer. My mom attended and subsequently was tested for Lynch syndrome. She obviously tested positive. By this time, she had already been diagnosed with endometrial cancer and received a hysterectomy with no further treatment needed. It was caught very early. Upon diagnosis, I grew up watching my mom do her yearly colonoscopies, but it really didn't have too much of an impact on our day-to-day life. But when I was 18, she was diagnosed with pancreatic cancer and passed away a few months later, 6 days before I moved away for college. So I always knew, not always, I would say by the time I was a teenager, I knew that I wanted to be tested for Lynch syndrome. Knowledge is power to me. I like to be in control of my health. In contrast, my brother did not want to be tested for Lynch syndrome, and there were a few reasons for it. It was really hard losing our mom, and I think he took more of the ignorance is bliss approach, in addition to genetic testing being very expensive. I think that there have been some improvements on helping with costs, even in the past few years, but he ultimately decided he did not want to be tested. Since then, he found out that he had colon cancer. He was 36 years old. He received surgery. It was early, and he didn't need any further treatment. Upon his diagnosis, he was tested for Lynch and found out that he had Lynch syndrome, He recovered, but now he has bladder cancer that he will begin treatment for hopefully in a few months. Maybe by the time this comes out, he will have started immunotherapy. It's early and fingers crossed for him. So I was 20 when I found out that I had Lynch syndrome. I had an overwhelmingly positive experience with my genetic testing. I was tested via the University of Louisville and Kosare Children's Hospital. I met with a genetic counselor. My dad came with me. And it was basically a discussion on the pros and cons of knowing that you have Lynch syndrome. I personally felt that the pros greatly outweighed the cons. I knew that I would be able to carry on with my day-to-day life, even with the diagnosis, if it did in fact come back positive. So I proceeded. I had the blood work done. I'm pretty sure I consented to being given results over the phone. So they called me while I was at college, and the genetic counselor asked if it was still okay for me to receive my results, and I agreed, and they were positive. And I remember feeling kind of sad, but not totally overwhelmed. And then I was offered another consultation with the genetic counselor if I felt it necessary. I personally was okay with the diagnosis. I had grown up, watching my mom live with her Lynch syndrome diagnosis, and I wasn't too terribly freaked out. So in some ways, Lynch syndrome affects my life greatly, and in other ways, not at all. Day-to-day life, not that different. But as an otherwise healthy 27-year-old, I go to a lot of doctor's appointments, or at least more so than the average person my age. And there are some mental implications. It's always weighing on me that my mom passed away at 60, and I just had my first child, and I kind of feel like the clock is ticking a bit. For females, it is recommended to receive a hysterectomy, either total or partial, when finished having children. So that's the stage of life that I'm really focusing on. It will be my next big step. But otherwise, I do my yearly colonoscopies every 2 to 3 years. I receive my endoscopy. I go for my skin checks. I should probably be seeing a urologist. Maybe I need to do that. But otherwise, Lynch syndrome, I'm able to live my life. I have a very happy, fulfilling life. And I'm thankful for the knowledge of my Lynch syndrome. Fortunately, where I live in Cincinnati, I have been happy with my physicians. Most of them are aware of Lynch syndrome and are aware of the recommended screenings. I haven't encountered any issues yet with meeting with a physician who just had no idea about Lynch syndrome. You will be hearing from Dr. Lipkin. He is working on developing a vaccine for Lynch syndrome. I didn't realize that such science was even available. No matter how early into the research and development he may be, this has potential huge implications for me as a previvor, as well as for my family, my children, my brother's children, other relatives, and many other patients who have received a Lynch syndrome diagnosis. It would mean so much to me if I was able to receive some kind of vaccine and not have to worry as much about Lynch syndrome. Because like I said, while it doesn't affect my day-to-day life, there are some pretty serious implications, and there is some worrying that is associated with having Lynch syndrome. So I hope you guys look forward. I have really enjoyed talking about myself and my experience with Lynch, and I hope you guys enjoy hearing from Dr. Lipkin and about the possible vaccine for Lynch syndrome. Thanks so much.
Hi, Gretchen. This is Dr. Lipkin talking from Weill Cornell in New York City. I'd like to thank you very much for your video log. It was very moving and very helpful and interesting, and I appreciate your sharing about your experiences personally and those of your family with Lynch syndrome and how much it's made a big impact. I want to say that among the details, I particularly was excited to hear that you had just had your first child and that you're looking to the future and towards the next generation. And this kind of makes me think a little bit about a historical perspective of Lynch syndrome. I knew Henry Lynch actually when I was a boy. Henry Lynch was actually my father, I should say, was a physician in New York, was a colleague of Henry's, and they used to go actually together in the Southwest to actually perform colonoscopies, or in those days, which was called rigid sigmoidoscopies. And they used to actually go in it was a large van that was sort of set up to be able to go to rural places where there were not really gastroenterologists who were able to do this. So, today, and for many reasons, we've had sort of much, a great, improvement in technology of the time. And I'd like to think, actually, since you were talking about your daughter and you talked about your grandparents and your parents, a little about thinking about it was 100 years ago that Alfred Worthen originally described Lynch syndrome. So Worthen was a professor at the University of Michigan, and in those days, professors used to have sort of typically a staff of helpers, like you'd seen in Downton Abbey or something like this. And Worthen had a seamstress, and his seamstress was an alcoholic. And he asked his seamstress once, why do you drink so much alcohol? And his seamstress answered, because people in my family die from cancer. And this was a time, before really what we consider to be sort of most of modern science and technology. At that time, Worthen, sort of thought about this, and there was sort of not so clear or established that human beings had genetics that behaved like other animals and even plants, which things that we now know to be true and kind of take for granted. So, since that time, since Worthen's originally discovery of what turned out to be Lynch syndrome in a family that was then rediscovered by Henry Lynch really in the 1960s, we sort of now think about all the progress that's happened in the past 100 years. In fact, in the 1960s, at that time, there was a sort of a change in technology, and that was the introduction or widespread use of what today we also take for granted, that is to be able to stain, tissue, and to be able to look at tumors under a microscope and to have an organized system of research where, that could be possible. So Henry was an oncologist at a time when it was sort of apparent that he said that he would see specific constellations of cancers, that is, families that had colorectal and endometrial, breast and ovarian, and such. And this is really that sort of technological, change or introduction of those techniques into standard medical practice in the United States really propelled him to then discover that, in fact, these constellations were related to the Lynch syndrome. Historically, we think in the 1990s, too, when the genes were discovered. And this revealed an important aspect, that colorectal cancers, for example, or any cancers really, they aren't all the same, but they're at the very distinct and that there are different subtypes when you look at the level of DNA and sort of in terms of scientific mechanisms. So the ability to identify sort of which types of cancers you had, and then the use of genes to be able to identify, importantly in a family, which individuals carried mutations such as MLH1, MSH2, MSH6, PMS2, and such, who needed to have increased surveillance and could have targeted surveillance, and those who didn't. Then we think sort of moving forward, I think another very important milestone in Lynch syndrome is the introduction of aspirin, or that is the identification in clinical trials, sort of an applied science, that aspirin specifically does seem to reduce colorectal cancer in Lynch syndrome patients, and the importance of that to be able to reduce the incidence of colorectal cancer, but also that aspirin does not really appear to reduce the rates of cancer at other sites. And this was sort of updated recently in The Lancet with, I think it was a 20-year update of the data from those clinical trials, and emphasized the importance of thinking sort of globally in terms of patients, in terms of their screening. We can also think, once again, the past few decades and then where we go from here in terms of the technology. I mentioned Henry Lynch, and my father used to use what are rigid scopes. And so as technology has developed, we developed, of course, going to more flexible scopes and the ability to perform sort of relatively quickly and efficiently and effectively for cancer surveillance, colonoscopy, upper endoscopy, capsule endoscopy, and MRI and other things to be able to provide, once again, sort of to detect tumors quickly. Then, we think in terms of the medical science, the introduction of immunotherapy has clearly been critical, and I think Matt Yergelin and some others are going to discuss that, so I won't get into details, but we know that from this we've made a lot of progress, but that we certainly still have a long way to go, and we're hopeful that as we go on this journey with you, to be able to help you and your family and other people who are like you. So the next 100 years, we think back about all the changes that have occurred, once again, in all these different areas, the medical science, the technology, really the introduction sort of we consider to be modern medicine. The next 100 years is actually likely to be much more exciting, and I'm very hopeful that we'll be able to, being the broad community, to be able to introduce, I think, a lot of exciting changes for Lynch syndrome, and I think for Lynch syndrome patients to actually be able to inform and really help propel the medical science, which I'll get to in a minute. So we talked before a little about aspirin and its importance, and that it's a standard of care as chemoprevention. So I practice here in New York City. New Yorkers have a reputation in the media, and there's some truth to it that they're kind of demanding. So in fact, I had patients who had Lynch syndrome and who sometimes say, or kind of in your face, patients who would say to me, okay, I have Lynch syndrome. Yes, I'll do colonoscopy. Yes, I'll take aspirin. But aspirin, really, is this the best you can do? Is this like modern, 21st century science? Isn't there something that's a little more sort of contemporary or high tech that I can do? While initially, of course, I was sort of taken aback when I heard this, in fact, that inspired me to really think, well, I hope that we can do better. And that sort of led to my thinking in terms of immunoprevention vaccines, so which we'd like to do sort of going forward. So a key point, I think, in the idea of a cancer vaccine is that there's great interest and potential among many people, both people who have Lynch syndrome as well as people who don't, and who like the idea now in the time of COVID, or as we say, after the start of World War C, the idea of, people are sort of more familiar with the idea of vaccines and of public health. So the idea of a cancer vaccine is actually an opportunity, I think, for the Lynch syndrome community really to be leaders. And the point is that there's, once again, broad interest in developing cancer immunoprevention vaccines. But if you're going to pick patients to be able, and it takes 100 steps, to develop a vaccine for cancers, to reduce cancers, if you're going to pick a group of patients to start with, Lynch syndrome would be likely on the top of most people's lists. And so we have an opportunity really as patients who have Lynch syndrome, to not only to hopefully, help themselves and their family members, but to help really the broader community as we can sort of work out some of the important details about really how to do immunoprevention vaccines, and to be able, particularly, to go kind of beyond colonoscopy and endoscopy, really kind of pan-cancer, to think about, how we can sort of, if there are 100 steps that are required really to get this sort of right, perhaps the Lynch syndrome if we develop this successfully, we could take 90 of those steps and then use it as the starting point to be able to help propel a broader cancer immunoprevention vaccine program that could have a great impact sort of beyond, not only in our community, but beyond. So the key point is that because Lynch syndrome is caused by mutations in DNA mismatch repair genes, tumors in Lynch patients have very high mutation rates. And so consequently, this evokes a very strong response from the immune system. This has been well appreciated for many times. And the idea that you have to have an immune response to be able to see sort of an effect from vaccination too supports well that we'll be able to make progress. I'd also like to point out, though, that that these will take time, and there's not just going to be kind of like one trial or one and done. I think we would expect to see multiple trials and multiple different sort of versions of different vaccines to be able to find, just like in COVID, there are different sort of varieties, different vectors, so to speak, to be able to pick which for certain people are the best one. There may not be one size fits all. And then once again, historically, I'm trained as a clinical geneticist. I like to think actually of another genetic disease and think forward of what we've seen in the past 10 or so years for gene therapy for a disease called Duchenne muscular dystrophy. Duchenne muscular dystrophy is a disease of boys largely because it's on the X chromosome. And, there were initial gene therapy trials that looked like there was sort of a signal, but it's taken actually a few years to be able to develop the technologies and sort of work out some of the bugs and to be able to deliver it. And then today, I think we have multiple really sort of exciting different versions of gene therapy for Duchenne, and we'll maybe get back to a little later some of the potential, at least for Lynch syndrome. So, the first, right now, we're talking about a vaccine and being able to test that uses sort of an adenovirus. And this is very similar actually to the COVID-19 for AstraZeneca and Johnson & Johnson's trials. But there are also other potential ways to deliver this. You had mentioned your brother was a little more fatalistic than you and said that he sort of didn't want to know. Well, the hope is that if we had something sort of better than aspirin, people, and was a little more contemporary, that perhaps your brother and others would take this as something that would be of more interest and more value to them, and would be able to encourage him to benefit from this. So we're once again starting off using these sort of adenovirus vectors, and one of the potential advantages is that you can actually have a lot of different mutations. So the key thing in the tumors from DNA mismatch repair deficient tumors in patients is that the mutation rates are so high and they're not random. We often think of mismatch repair as being kind of like a spell checker, but it particularly works in certain sequences that have long strands of mono, di, and tri, and tetranucleotide repeats. So 10 A's in a row that fall in a gene called the TGF-beta type 2 receptor that lose one of those in about 60 to 80% of colorectal cancers that are mismatch repair deficient, and therefore have a frameshift mutation. And this is something that can be targeted with the vaccine. There are sort of many other types of mutations that can be used, but then also we need to take into account different people. That is, that people's immune backgrounds as well as their genetic backgrounds are actually a little different. And so sometimes that's another variable that we will take into account for this. And because when we have effective vaccines, we want to make sure that they're useful for really can benefit by all ethnic groups. So, in addition to sort of European ancestry or so-called, as we say, white people, but also people of color, Latinx individuals, and many and Asian in ethnicity, and of course other groups that we want to make sure can benefit as well. And moving forward, we may have different versions of vaccines and for this. So right now, the vaccine that's being tested that uses this kind of adenovirus we're waiting on the FDA. It's being tested in patients who have mismatch repair deficient cancers that are metastatic. The vaccine appears to be safe so far, which is encouraging. And so we're waiting and hopeful that the FDA will let us move forward to test this in Lynch syndrome patients as previvors like yourself. But it's likely that there'll be other versions of this, perhaps using sort of like a RNA as a template, or in this way that for COVID, there are kind of RNA vaccines. One of the things that's actually come up as well is potentially whether one can use actually checkpoint inhibitors, which are the drugs that are used for immunotherapy for patients who have Lynch syndrome or mismatch repair deficient cancers. However, the issue is that checkpoint inhibitors have a lot of side effects that in people who are previvors and relatively healthy may be very problematic. So the immunotherapy that's being done right now is acceptable in terms of its side effects, which include kind of like inflammation of the colon, inflammation of which can cause sort of a lot of pain, and so diarrhea and other things. Lung inflammation, which can cause problems with coughing and really effective breathing, to be honest. And then other sites, including the liver, inflammation involving the pituitary, which produces hormones that affect sort of stress response and reproduction and such. And so we think that checkpoint inhibitors may be a little too strong for people to use in a previvor type of setting. And so we're sort of looking more towards these, once again, taking some of these mutations that occur not just in one tumor, but across tumors to be able to use as the substrate for vaccines. So I'm very optimistic that we'll be able to make sort of progress in this. I do think that once again, it's going to take there could be a few different types of vectors and types of trials. And I do believe that we will be able to take what we can learn, and that people who have Lynch syndrome who are enrolled in these trials can really help inform cancer prevention vaccines for other groups in the general public once we get the basic technologies down. Some other aspects that I'd like to point out, sort of looking forward for patients in Lynch syndrome and thinking about your daughter, one of which is the development, which is very exciting, that we and others are working on, of liquid biopsy, or so-called cell-free DNA. So there are now tests. In fact, next week, actually, I kind of have a panel I'm on that talks about the use of these sort of blood-based biopsies that are pan-cancer detection tests. So these work pretty well in patients, once again, who have established cancer or in remission and looking for the cancers that come back. And those tests can detect actually down to about 1% of the DNA, the cell-free DNA that's sitting around in blood. But we think we can do better. We think we can do this particularly for Lynch syndrome because of the specific types of mutations, the signature that occurs in mismatch repair deficient cancers. I also think we're going to see better stool-based tests, and then I'm hopeful that this will enable us to reduce the frequency of colonoscopy that's needed. So this too is sort of a work in progress. Once again, the idea of a blood test is exciting because we can potentially detect sort of the same molecular defect in Lynch syndrome mutations that occur in cancers, but we can do this pan-cancer. And I'm anticipating in the next few years that we'll get much better in terms of, there's been tremendous really progress in the past 5 or so years. And I think we're going to see sort of better tests for early detection in Lynch syndrome patients and be able to monitor this and then to track down where the tumors are. I'd also like to talk a little about this idea of potentially correcting Lynch syndrome. So this is sort of something that is, at the moment just sort of an idea, but we know that for other genetic diseases I mentioned before, like Duchenne muscular dystrophy, we know that it is possible to use gene therapy and gene editing to be able to replace mutated genes. So while we're not doing this at the moment for Lynch syndrome, I do envision a time not so far in the future when we will be able to consider doing this and to be able to be able to tell, how well. Sorry, I was just checking the time on my lecture. I think we'll expect a time in the near future when we may be able to consider the use of gene therapy. And of course, now we for many years have had the established technique of in vitro fertilization for individuals who choose to have a child and not to pass on a Lynch syndrome mutation. But as we get better and better with detection of cancers and with vaccines for immunoprevention, I'm hopeful that by the time your daughter is older, that we will largely this will be something that's much more routine in the way we think of kind of like how we would treating antibiotics as we use for infections. I very much am looking forward to meeting you and your family, and I was very touched by your presentation. And I just want to say that there's a lot of people who are working on this, who are interested, and we want to help patients with Lynch syndrome. And once again, we think that this can be actually a paradigm where people with Lynch syndrome can actually help the broader community as well, and to establish the idea of cancer vaccines. So thank you for all you've done, and Godspeed.
That is really exciting stuff. So thank you both, and Gretchen, of course. Thank you for coming on and discussing this. So
Be here.
You are there. Good. So of course, like anything, the dogs are outside barking as soon as I start speaking. So I apologize in advance, but it's going to happen. So we do have a bunch of questions for late on a Friday, which I'm excited about. So I'm going to get to that real quick. So one question that was raised, and to an extent it could be for Gretchen, or it could be for any of us who have Lynch syndrome, and that is regarding, having children, knowing you have a mutation, and the question is asked of me all the time is what would I have done if I had known? I mean, obviously Robin and I were older, and I don't have the answer, and it's interesting to see how that is asked and how it's responded to. So the question posed out there is was anything done to try and prevent, or were you okay with it, so to speak, if you don't mind me asking that question?
Yeah, I don't mind at all. I think it was shortly before I became pregnant. I have a son. Sorry, Dr. Lipkin, you referred to my daughter, but he might make an appearance. He's playing in the playroom. Awesome. Jean Edelstein, or Edelstein, I'm not sure how you say her last name. She actually published a book. She has Lynch syndrome, and she discusses how she went through IVF, to ensure that her embryos didn't carry the Lynch syndrome gene. And so I knew about it, but I personally, I didn't want to do IVF because of the cost and just because of all of the side effects that go along with it. Do I have some guilt about passing on Lynch syndrome to my son? Absolutely. But hopefully, because of physicians like Dr. Lipkin, maybe it won't be as big of a deal for my children. I don't know if maybe if I was having children later in life, where I had to worry about fertility issues, I mean, yeah, maybe I would have done something like that. But where I'm in my 20s, I'm an otherwise healthy female. It didn't really cross my mind all that much. That being said, when Billy was born, my husband, he's a pediatrician, and he was really, it's like once Billy was here, that's when he was like, oh my gosh, we have this baby, but if he has Lynch syndrome, what do we do? So we went ahead and set up an appointment with a genetic counselor at Cincinnati Children's, who basically said what I thought she would say, let's wait until this kid is either a mature teenager, if he is a mature teenager, or until he's 18 and can consent. So until then, I won't worry too much.
I can hear him in the background. And we'll cross that bridge when we get there. Otherwise, I mean, I'm going to be very open with him about my screenings. It's a part of my life. So he'll know about Lynch syndrome. I'm not going to keep it from him. But yeah, for me personally, I didn't go the IVF route. However, I mean, if you have the funds to do so, I totally understand why other pregnant people make that decision.
So I think Billy's talking to our dogs. So that's ending to a very long, fulfilling group. So speaking of firstborn, my actual son submitted a question, so I'm going to read that one. I'm going to pull rank and put it out there. So,
can I respond actually for a minute to the question about IVF?
Sure.
So Gretchen, thank you once again for your wonderful video and for your wonderful commentary. So for this question of doing in vitro fertilization is a highly personal one. And there is no, I just want to state very clearly, there is no right or wrong answer. This is a personal choice. And I can say that, among our patients, at least just in our practice, it's sort of, I'd say that, probably fewer than half choose to do IVF because of some of the logistical and financial hurdles that you mentioned. But it is sort of possible. But so there are, getting the hormone injections and the expense is several $1,000s. And a course of IVF is $20,000 or something like this, or even more. So it is a substantial, kind of investment. And, in general, the thinking is that, once again, I mean, you think about the past, I talked to a little, I like history, and, you think about sort of all that's happened in the 20th century in terms of medical science and Lynch syndrome, 100 years from now could look pretty incredible. So, I'm hopeful that for future generations, we'll have a lot more to offer, the next generation. And in terms of, and in particular, I'm very excited at the moment. I think I want to point about this, obviously the issue of vaccines, but all immunoprevention, but the question of liquid biopsy. So, just to go over that data without spending too much time. So the best data that are out there by this, are from a company called Thrive, which is a spin out from Johns Hopkins. And basically the net is that they did a 10,000 patient trial where the prevalence of cancer was prospective, was less than 1%. It was about 0.4%. And because of that sort of handles this kind of false positive issue. So in their test, the screening, colonoscopy, mammography, this kind of stuff, and they actually had women who were 65 to 75, they picked up about 25% of all the cancers that occurred during the trial. And then the liquid biopsy doubled that to about 52%. So that's great, but I think for Lynch, we can do a lot better because of microsatellite instability, this mutation signature. And so I think that we can do a lot better for that. And I think that's sort of the next thing really to help screening cancers for previvors for patients without Lynch. And then since we're on the subject of dogs and kids, I just like to introduce my dog. Aldo is a basset hound, a beagle mix. And so in New York, we call him a bagel.
Nice.
And I think it's if I'm in my office now, if I were home with Aldo, he would be probably eating the camera. So therefore, I decided to come into the office to do this. Anyway, so thank you.
And as you alluded to regarding Thrive, if I'm not mistaken, one of the co-founders is Bert Vogelstein, who was also in the lab that discovered microsatellite instability.
Correct. That's right.
So, everything comes full circle after if we all live long enough, and we're pleased to see that type of science coming. So can I get to my son's question now that he's anxiously waiting? I'm sure I'm going to hear about it.
Now that I've introduced my dog, yes.
Thank you. So my son's question is, does the vaccine target cancers or the gene itself? And if it targets the cancers instead of the gene, why?
So mismatch repair is a kind of a spell checker, but once again, it particularly affects certain repetitive sequences like 9 A's in a row, or CA, these kind of repeats. So it's not really a 3 billion pair genome. It's really these sort of particular sequences that really have high mutation rates. So because of that, you have recurrent mutations. So I mentioned there are genes where 60 or 80% of colon cancers have exactly the same mutation. We now know there are sort of, dozens and hopefully hundreds of these that are occur in about 10% or more of at least colon cancers with Lynch patients. So this is the whole, so the substrate for a vaccine is these recurrent mutations, not MLH1 or MSH2. And it's another, but there are many questions. One of which is, for example, how much is too many? How much is enough? And maybe it's too much. So the current trial that's being run, which I guess you should say, is being sponsored by this company called Newscom, and is being run at Weill Cornell and MD Anderson. Eduardo Villar-Sanchez is the PI at MD Anderson, has been sort of instrumental really in bringing this kind of work forward too. So I'd like to give Eduardo a shout out. The trial will first enroll 12 patients. So it's being tested, and so far appears to be safe in patients who have metastatic mismatch repair deficient colon cancer, the sort of patients like Matt Jurgelin was sort of talking about. And in sort of people who are healthy, the first trial will look at MLH1 and MSH2 mutation carriers. MSH6 and PMS2 may require actually some changes. So that's another aspect. And once again, it uses an adenovirus that has about 209 recurrent mutations from Lynch, from mismatch repair deficient colorectal, stomach, and endometrial cancer. But I anticipate there may actually be also hopefully RNA type trials in the same way that for COVID-19 there are RNA vaccines, there are adenovirus vaccines and such, and that I think we'll use some of these liquid biopsy assays actually to be able to monitor what's going on.
Yeah, that's great. Eduardo is a friend. He was part of the Living with Lynch last year that we did in person at MD Anderson. So, and you answered the next question, which was, have trials started, and are they gene dependent? It sounds like that is. And of course, people want to know, how can they participate? So we'll obviously to be continued, and thank you.
I can answer that very briefly. I will say that when they do these type of trials, safety is a big issue. People want to make sure, particularly in, as they're called, kind of phase 1 trials. So because of that, there are a number of visits. You have to come in kind of every week or two to have your blood drawn and things like this, and so that the immune system can be monitored, the way the immune system is reacting, that people aren't having sort of autoimmune type problems and things like this. So so pretty much I think it means that for the first trial, people in the Houston area where MD Anderson is located, and in the greater New York area sort of probably make the most sense, because you do have to come back and forth. I have got some questions from people in states that are plane ride away, and it's probably a little too much to do that for the first trial, I think.
Well, if you need me to go to Paris for the Newscom trial, let me know.
But they're in Rome actually. So
Rome. All right. Well, I haven't been to Rome yet.
Rome and what is it? Swiss. One of the
Basel.
Yeah, I think it's Basel. That's right, in Switzerland. Thank you.
All right, well, I'll volunteer for that one too.
During ski season, right?
Well, I'm in soccer. I'm not a skier, but I'll do soccer. What do you foresee as far as like the long-term efficacy implications with the potential vaccine? Any crystal ball?
So the first question, is just sort of, is the vaccine really inducing a strong immune response? And that'll be and is it safe? These are the main questions for the first study. The second question is how long that immunity lasts. Another factor may be actually age, so that, for instance, younger people tend to have more robust immune systems, as people are probably kind of aware as they go through the life cycle. And so this is a sort of types of some of the analyses we want to do. We also want to make sure, once again, that it's that we're making that individuals who are of color, you know, and are sort of, you know, non-white essentially also benefit, and that we have kind of the right mutations for all of the tumors.
Very cool. So here's hold on, I'm reading, so forgive me. Do you foresee the changes in the FDA having an effect on your schedule, for better or worse?
So I am on one of the FDA committees, the FDA, the Clinical and Molecular Genetics panel, that sort of works with like not with vaccines, actually works with diagnostics and liquid biopsy and these kind of things. So the issue with, I think he's referring to COVID and these sort of emergency things because of the COVID-19 emergency.
Well, we're seeing a lot of
besides COVID, it's unclear really what will happen with the agency kind of moving forward. There's been one of the things that in, you know, the past 4 years, I can say, you know, there's now, like, for instance, much fewer FDA panels. The FDA has just generally been less active, and it'll be interesting. I think we really have to kind of wait after the election to kind of see, you know, we may have a new commissioner and the agency may change a little bit. But at the moment, the kind of feedback that we've had is that, you know, they really want to see that this is safe before using it in people who are otherwise healthy, because, you know, to make sure that we're not causing, you know, autoimmunity and things like this.
Yeah, but I mean, not just on the COVID side, but I think we're all seeing a lot of changes in the FDA in terms of the number of drugs being approved. The pipeline has just gone up incrementally with what has been approved over the last several years. And I think it's a good thing. I'm not saying it's a bad thing. I'm saying it seems like some of these really impressive drugs have gotten through relatively quickly, or maybe not necessarily quickly, but seemingly at the same time.
I want to say that I think it's very important and great that Alive and Kicking and Man Up to Cancer and some of these other organizations, advocacy organizations, play a very important role actually at the FDA in getting things approved. I mentioned Duchenne muscular dystrophy. The Duchenne advocacy groups were very, very active with Janet Woodcock and really convincing her that this was an urgent medical need. And that ended up, you know, I think making a big difference in terms of the speed with which with the therapies for Duchenne muscular dystrophy were approved.
So different question. Other types of genetic testing for Lynch syndrome patients for understanding different aspects of their own health. I mean, we're not just talking about the Lynch itself. I mean, like how a body responds to hormones and detoxification. Are you seeing anything out there? Any thoughts? I mean, does pharmacogenomics play a role in the treatment of a Lynch patient? I mean, thoughts?
So Matt Yergelin talked a little about this question of sort of the weight of evidence, and sort of he commented that, you know, checkpoint inhibitors obviously, I mean, have a lot of benefit for mismatch repair deficient cancers, but, you know, it's not so clear because it hasn't been really demonstrated yet. There is a trial in you know, early phase, you know, 2 colon cancer, you know, to see if this is beneficial or not. And so he took a more cautious attitude and wanted to wait and see. In terms of the pharmacogenetics testing, in fact, the FDA has actually been a little more active in ratcheting down some of the expectations. And actually, the FDA recently, meaning in the past couple of years, released guidance actually saying that a lot of the pharmacogenetic tests were not necessarily scientifically they're correct, but there wasn't a lot of clinical evidence. And so recommending that people are a little more cautious on pharmacogenetics. So the point is that the Lynch syndrome mutations have a major effect. You know, sort of kind of a binary kind of yes/no effect in terms of how we clinically manage things. The pharmacogenetics and some of these other tests is sort of not clear. They're scientifically valid, but it's not clear that it's clinically has clinical utility. And therefore, it's unclear really whether they're useful or not at this point in time.
Got it. So thank you. Thank you both, and Billy, of course. And and your bagel. So we do have a surprise at the end. So, but I do want to do some thank yous for everyone here. So, first off, thank you once again for our sponsors, Merck and Foundation Medicine. Thank you to Erin Peterson of the Colon Cancer Coalition, who both have been and continue to be a valued partner with Alive and Kickin' in our goal to improve the lives of individuals and families affected by Lynch syndrome and associated cancers through research, education, and screening. Thank you, of course, to Heather Hampel, genetic counselor at the Ohio State University Comprehensive Cancer Center, as well as all of the esteemed clinicians who gave their time to be here. And thank you, of course, to all of the Lynch syndrome patients who have been here. Thank you to Robin Beth Dubin, Executive Director of Alive and Kickin', who continues to coordinate all of the efforts of Alive and Kickin', including the migration of the heroic registry, which we started with the Genetic Alliance. Speaking of the Genetic Alliance, so we are now closing with a special ending meditation led by our esteemed colleague, Sharon Terry. So Sharon is president and CEO of the Genetic Alliance and an Ashoka Fellow. She is an avid student and facilitator of Gestalt awareness practice. So I have my sweats on, so I am going to be turning off the camera and making myself comfortable for a nice meditation. I hope you will join us. And thank you once again for all of you for being here. This has been David Dubin, and I am Alive and Kickin'.
Hello, I'm glad to join you at the end of your conference here. I know that you've been working hard to support those who have Lynch syndrome, and that some of you live with it and some of you work with people who have Lynch syndrome. I'm going to invite you at this point to really come into yourself, into your space, and into support for going forward to start to digest all that you've learned and the support you've felt here. So if you're inclined to do so, close your eyes, settle yourself in your chair or your couch or wherever you're sitting. And feel the seat beneath you. While lots of things might be uncertain, for some of you, new diagnosis, treatment, for those of you in research, the next puzzle, and those of you in care, striving to alleviate suffering, this seat is real and concrete at this moment. This seat is supporting you, held by gravity, which we can depend on. It may seem like a small thing, but being confident that this support is always here is something you can always return to. And in feeling this support, imagine whatever will help, that this is the lap of the earth, that this earth, while all of you are scattered all over it, is holding us all. Maybe like a tree, put down a root and feel that connection to all life, everything that's living, everything that's supporting this life. And as you sit here, bring your whole being, noticing that you have a top and bottom half to your body, a front and a back, side to side, and surface to core. And noticing too, any place this body feels okay or even feels good. Might be as simple as your big toe. Might be as big as your chest. As you let go and let down, lean into this support, knowing you're held. And turning a moment to your breath. If you've ever learned how to breathe in any kind of special meditation, just forget about that. And for this moment, with nowhere to go, nothing to do, and no special way to be, just ride your breath following impulse. Maybe with a touch of gratitude that air is also abundantly available and constant, and that this breathing you've been doing since the moment you were born is serving you at this moment. Just follow your inhale and your exhale. And when you have time to stay in a place like this and linger, even if it's just for a few minutes, allow yourself to feel your breath, whether it's shallow or deep, slow or fast. And now broadening your awareness out again to your whole body, allowing any letdown, any relaxation or loosening. Any place of tightness or pain, just saying hello. And anytime thoughts are grabbing you, just notice you're on the train of thought and get off at the next station. For the moment, staying in your body, in your seat, in your breath. And if you're on mute, you can exhale loudly, elongating the exhale. Even with some sound. Leave your body or your breath, but to open each of your senses one at a time, seeing what comes to them. Hearing, smelling, even smelling nothing. Tasting. Touching. And eventually sight, light. Bring us in your seat with you. And coming back into contact with the squares in front of you. The people with whom you share this quest. as you go throughout the rest of your day and evening, perhaps trying to bring a little bit of, and maybe revisiting. And grateful to Robin for the invitation to come to you this way today. Happy to support you as they, Robin and Dave, do so well, and all the others at Alive and Kickin'. May you be alive and kicking. Have a good day.